I loved the curtain. That was so cool. Yes, hello everyone. I'm always glad to join you all to talk about my two favorite topics, and those are healthcare reform and management excellence. And Norval, do either shoot me a little note or cut in if there's any trouble hearing me today.
Okay.
Great. And I think as Norval covered, I know y'all may have some questions. Please just type them into the chat box, and I'll do my best to save some time to the end to look at those. As I said, one of my favorite topics is healthcare reform. So today I'm going to be talking about our nation's healthcare crisis, and it is in crisis, and the resulting disruption to across our country, across various industries that depend on healthcare, including my own. I'll be talking about how I am helping my team of state government health policy analysts to not only cope, but to perform within that context. I'm going to be speaking to you all today from that perspective as a middle-level manager. I'm within an organization that is struggling to keep up with constant change, an organization that struggles with resource limits and unclear and often shifting priorities. And I'm assuming that sounds familiar to many of you. My organization and its challenges are not unique, and I'm hopeful that there will be some ideas shared today that will help you as you chart your own course. You may notice on my introduction slide the image in the middle. That is Hogwarts. As I was preparing the slides for today, I had a conversation with my son, and I was telling him about my topic, and I was talking to him about policy analysis, policy analysts kind of work that we do. And so I asked him, I said, from pop culture, is there any character that you can think of as I describe the policy analyst? What character comes to mind? Because I needed a theme for my slides. And his response was Professor McGonagall. And if you all know Professor McGonagall, as played beautifully by Maggie Smith, she is one of the principal characters across the Harry Potter movies, one of the professors from Hogwarts, and you'll see her image come up in one of my slides coming up. So with that, I was inspired, and so you'll see Hogwarts, Harry Potter being the recurring theme throughout today's lecture. All right. So, learning objectives. Today I'm going to describe Medicaid's value as a source of health care insurance for the poor. I'm going to summarize the crisis in United States healthcare and why we are at a crisis point. That's going to be important to set the stage and set the context for the kinds of change that I have been leading here in my organization and why. I hope that you come away learning some unique challenges and opportunities to applying innovation within the kind of work that we do. And hopefully you will come away being able to describe how to implement quality management principles, tools, and practices into plain language that resonates with regular people, which is my mission. Let's start with Medicaid. What is it? Very commonly, one of the first questions I'm asked when people hear I work for Medicaid is, what's the difference between Medicaid and Medicare? Medicaid is an assistance program that covers low to no income families and individuals. Medicaid and Medicare, let me back up there. These are two different laws, two different federal laws and two different sets of regulations. Medicaid is the mechanism by which states assist the poor with accessing health care. Each state's Medicaid program is different. Each state runs their own Medicaid program. But while all states play by the same basic set of rules, there are ways that states can customize their processes to provide assistance for their state. Medicare, on the other hand, is 100% federally funded. It's a federal program, federal law, federal regulation. And it is, at its core, it's government insurance for the elderly and the disabled. To put it simply, Medicaid is for poor Americans. Give aid to the poor. Medicare is for the elderly and the disabled without necessarily a regard to income level, and take care of the elderly. All right, all states Medicaid and overview. Just to hit some high points of what Medicaid does for the citizens in our country. It covers health insurance costs for over 70 million Americans, and that's about 1 in 5. A lot of us. 43% of those that are covered through Medicaid are children. Okay. 2 in 3 persons covered. 2 in 3 people who are in nursing homes are covered through Medicaid. 1 in 3 births. As far as the spending, 53% of Medicaid spending goes to what we call long-term services and support, and that's the kind of services for the elderly and people with significant disabilities. It includes nursing home, but it includes a lot of other community supports like adult daycare in some cases as an example. Then behavioral health. I think it's interesting to note that Medicaid is the #1 payer of behavioral health services in our country. So Medicaid is everywhere, rural and city, covering people of all age groups. But the core feature that those folks that are covered have in common is income, typically deep poverty. Now, looking at overall expenditures in healthcare, I believe I said here in my last slide, or maybe it's coming up in this one, I believe it's $500 billion is spent on Medicaid across our country. But to put that in context, consider that $3.2 trillion are spent on healthcare in our country per year. When I was preparing these slides, I was having a hard time wrapping my mind around what is $1 trillion. I sat down with my Excel spreadsheet and I was having trouble putting in enough zeros. It boggles the mind. And I think that, you talk to anybody who's involved in healthcare reform, healthcare policy, our concerns about the growth of our overall gross domestic product that is spent on healthcare in our country is growing pretty rapidly. In the last 10 years, we've gone from 13% to 18% of GDP. So of all the money spent in the United States on various goods and services, 18%, almost 20% is spent on healthcare. This chart is a nice one. It breaks down and shows, relatively speaking, how much we're spending on healthcare via out-of-pocket versus private insurance, Medicare, Medicaid, other types of insurance, and then sort of that catch-all other group. The take-home from this slide is that rapid rise, that increase in our overall GDP. If this rate continues, we're estimated to be spending 25% or 25% of GDP on healthcare by 2025. Okay, 3.4 trillion last year. I think I said 3.2 trillion a moment ago. I need to correct that. 3.4 trillion. We rank #1 out of 11 of the world's highest income countries. So out of 11, we rank #1 in the amount that we're spending on healthcare as a proportion of our gross domestic product. Now, just a little bit about the state of Virginia, where I live, obviously. And as I said, every state's Medicaid is different. There's certainly going to be some commonalities, but really, you've seen one state Medicaid, you've seen one state's Medicaid. Here in Virginia, I'd like to show this particular slide because I think it says a lot of information in one slide. You've got the average annual cost per member in the age, blind, and disabled category versus children versus adults and pregnant women. And those are typically the three broad categories that we talk about when we talk about our enrollees or our members. On the right hand, look for a moment at the numbers of enrollees. Okay, 24% of those enrolled in Medicaid, and then we've got about 7 million enrolled in Medicaid here in Virginia. The age, blind, and disabled make up 24% of that. Whereas if you look at how much money is expended, 68% of money is spent on those in that age, blind, and disabled category. So that's where the money's going, all right, to care for those people with those long-term, chronic, serious kinds of conditions. U.S. healthcare. Why do we say that we're in crisis? First of all, we talk about national spending cost. I've already gave you some numbers about national spending that we talked about how it increased from 13 to 18% of our gross domestic product in the last 10 years. We're spending about $3.4 trillion. We rank number 1 out of 11 compared to other high-income countries in our spending, the proportion of spending. Typically, most related to high-cost technology, prices for the services, items, drugs, is the driving factor there. The crisis, though, is not just about cost. It's also about access. 12% of Americans are uninsured. Remember, I said we rank 1 out of 11 in our spending. Well, we rank dead last, 11th place, compared to other countries in terms of equity, in terms of the numbers, the proportion of our population that is uninsured. Quality, we also rank last in terms of efficiency, last in what's called mortality amenable to healthcare. So thinking of conditions that are more preventable, conditions like diabetes and heart disease. Efficiency, I mentioned that we're last in terms of efficiency. We're really talking there about cost to benefit. So how we're managing administratively the cost of healthcare. We have this poorer performance on chronic conditions and mortality from some of those conditions, like I mentioned, heart attack. Where we do well is in cancer treatment. Our mortality is, relatively speaking, much lower on cancer compared to other countries. So we are doing a good job there. Also contributing to our crisis is our polarizing politics. Politics are really using healthcare as a central tool in our partisan politics. It is the political football. Political careers rest on keeping healthcare discussions divisive. It's always interesting to me, we often talk, we see conservatives or Republicans, we think of them as concerned about cost. Liberals or Democrats, we think of them talking about the access issue. But those two issues are two sides of the same coin. The high cost impairs access, and then problems with access drive up cost in terms of people with more chronic conditions that don't get care until it's at a serious point. So it's interesting how those work together. All of this brings us to instability. You see it in the headlines, insurance companies pulling out of the federal marketplace as insurance providers there. Premiums are unpredictable. It's very difficult to predict from one year to the next because of all the changes happening in regulation as well as legislation. We've got dramatic fluctuations that happen in drug pricing. There's this lack of transparency that everyone talks about. All this leads to this instability. Instability disruption. And there's our friend Voldemort, and sort of the king of disruption right there. I believe that's a scene from the final battle that took place at Hogwarts with Voldemort and the Harry Potter team. So again, polarized politics, rapid cycle legislation being churned out with the pendulum swinging from extremes. Regulations follow the legislation. Business financial decisions that focus on short-term profits and market share. Technology is also a huge factor in our disruption. It outpaces culture and paradigm, outpaces the resources needed to fund it. And there's no signs of any of this improving anytime soon without a planned and aligned response from political, business, government leaders. They've got to come together and work together to solve the problem. All right. The sources of that disruption, I want to say a little bit more, particularly about the Affordable Care Act, often called Obamacare. Because the Affordable Care Act is such a constant presence in the work that I do. It is an attempt to deal with the crisis. That's what it is. Whether you like it or not, you need to acknowledge at least that it is a symptom of the problems. It is an attempt at solution to the problems, the crisis elements that I already mentioned. The Affordable Care Act was enacted in 2010, and it represents dramatic change to the way health care is delivered, paid for, managed, monitored, okay, provided. It has provisions that very directly address each part of the equation, the cost, as well as the access, as well as technology. Enacted in 2010, however, provisions coming from it, the provisions that then lead to the regulations, the rules for how we're going to implement the law, they come out in a rolling manner, okay? For example, they extend until 2023. The latest, most regulation that we have to come in compliance with here at Medicaid comes out in 2023. So while Obama has left office, the effects of this law are far-reaching, and we won't see the effects until at least a decade or so down the line. It's really too early to assess the Affordable Care Act, and also with all the disruption and crisis that politically that came out around the Affordable Care Act makes it extremely difficult to assess its effectiveness based on its intent. But if you look here, gosh, if you count those up, 1, 2, 3, 4, 5, 6, 7, like there's 12 to 14 very specific kinds of categories of provisions that are addressed through Obamacare or ACA. It's incredibly comprehensive set of law. So public policy analysis and the problem that we face here at my agency as we grapple with these rapid transitions that are happening in legislation and regulation at the federal level, but also at the state level. I work for, our acronym is DMAS, that's the Department of Medical Assistance Services in Virginia. We are one of 11 agencies that report up to the Virginia Secretary of Health and Human Services. And we have about 550 full-time staff. We have the largest annual budget of any single state agency, and that's about $9 billion annually. Our staff engages in heavily analytical work, and that's going to be really important as I get into my discussion of management innovation that I've been deploying here. These are very analytical types of folks, highly educated, very experienced, very tenured typically. The activities across the agency, they range from investigation of allegations of fraud and neglect, for example, to managing a huge IT information system that tracks the million persons on Medicaid in Virginia. We manage the appeals processes that happen with coverage decisions. We monitor, manage a dozen or so managed care contracts that actually provide the health care insurance to our members. We oversee development and implementation of various programs and projects that address special populations. For example, those in long-term care or those with behavioral health problems. Personally, I joined DMAS about 13 months ago as the operations manager over our policy research division. There are about 19 divisions in the organization, and I'm one of 19, and our division is called the Policy and Research Division. I came to DMAS with no state government experience, none. I had no Medicaid experience. My background was healthcare administration and psychology. But I was brought on board for my operations management, change management experience. I am a certified organizational manager, manager of quality, organizational excellence. I always have to think through the acronym. And I was really brought on for those qualifications. The leadership of this organization needed some major change to happen within the division that I'm part of, and that's what I'm going to be talking about next. So it's helpful to talk about, so I was asked to come in and work with the policy researchers and analysts to help this group really transform, to evolve in order to meet the needs of a very different kind of regulatory climate that we're in right now. The policy analysts, what do? They survey legislative, regulatory news and information. It is a daily thing that we do, both from the state level as well as from the federal level. We plan the institution's response in terms of compliance and understanding interactions and impacts of these different rules as they come down and how they're going to affect different parts of our agency, to try to help our leadership plan that challenging, aligned response. We implement the new or revised policies. We aid the various divisions, units, teams throughout our agency in coming into compliance. And then evaluate the effectiveness of that. This is taken from a generic form of our position description for policy analyst in state government. Just look at some of the verbs here that we develop, we implement, we interpret policies. We're researchers, we analyze, and we advise, all around policies, procedures, laws, regulations. Okay, back to our Harry Potter theme. We see Hermione in her laboratory, and it sort of captures the personality of many policy analysts. The average tenure of the analysts of my team when I took my position, when I started a year ago, was around 20 years. So they're tenured individuals. They are quiet, thorough, perfectionistic in their work. They have tremendous Medicaid and institutional DMAS knowledge, and that's key. All right, our leadership, as I said, the leadership brought me in order to assist the team in transitioning to meeting a kind of a different environment, a different set of expectations that are coming out of the current regulatory environment. The leadership saw the team as slow, indecisive, siloed, and ultimately the product or service provided just had little tangible value to the day-to-day work that the leaders and what was needed. So in other words, that thoroughness that I mentioned was seen as slow. That careful, perfectionistic, risk-avoidant approach was seen as indecisive. Quiet, studious approach seen as siloed. Okay. with the primary product or service often being what you all would think of as a research report. Could be from 20 to 40 pages long, may take days, weeks, even months to complete topic assignments, which is why it led to little value. And there's probably my favorite, Professor Snape, and he's displeased. So the problem, and I've already said this, with this rapidly changing regulation, social political controversy, technology churn, the agency growth, I didn't mention that, because of all that's going on in healthcare reform and Medicaid reform in particular, we've had tremendous agency growth in terms of staff in recent years, which has led to a decentralization of agency policy response, which makes an aligned compliance response more difficult. How about the analyst, their perspective? When I talked to the team, they talked about a lack of direction, lack of newer tools and training to meet the needs in this changing climate. A word that was used that stuck with me is that folks felt adrift. They knew that they weren't meeting expectations, but they didn't quite know what those expectations were or how to meet them. So there was the problem, and now let's talk a little bit about the solution. Essentially, our people, our tools, our processes no longer worked in the current climate of disruption. Leadership was needed for this team at a new direction. We needed to clarify our mission, our purpose for being here, which we did. With input from our leadership and input from the team, we came up with this purpose statement that we are here to ensure a timely and effective, agency-wide and aligned response to new or revised federal regulation. Emphasis on timely and effective, because there lies the challenge when working with policy analysts who've been trained, maybe trained a dozen years ago. Our methods need to change, and that's been tough. So leadership, I through interviews with my senior leadership, asking them exactly what are you looking for from our team. Speedy, agile, decisive, aligned, okay? And then I said, what would that look like? What would that sound like? And the kinds of things that were wanted was like a more frequent cycle of communication. Our leaders don't want to wait 2 weeks for a 40-page research report on a topic. Instead, they would much rather have very frequent updates and status reports and short sentences, short bullet points on what we're learning and what we're recommending, what direction that we're headed. But that's more valuable than a final beautiful report. They want face-to-face interaction. That was one of the very specific things mentioned. We all work in the same building and we're actually on the same floor as our senior leadership team. So we need to get out of our cubes, get out of our offices, and they want us to come to them and report out on things that we're learning in the regulatory world. I'm moving away from the narrative style of reporting that we all learned back in college, of research reports with footnotes and bibliography and headings and so forth. Looking more for templates, looking more for bullet points, focus in on making recommendations, putting yourself out there, putting your neck out a little bit. The way one leader put it to me is, don't make me follow breadcrumbs. Lay it out, cut to the chase. What are you saying? What do you think we need to do? Because the leaders themselves are also struggling with information overload. And so they need a different approach. They need us to be more directive with them, frankly, because there's just so many decisions they have to make daily. And then this final bullet is department-wide vantage point. And by department here, I mean organization-wide. That comes back to that alignment. We were concerned about the silos that had developed within our agency with the best intentions, various teams kind of working on their own policy projects, but then, down the line, the finance project is actually conflicting or clashing with the appeals division's project. So we need better communication and alignment across the agency in our work. Solutions. So we were looking for a team of policy project experts with the tools, training, the clarity of mission needed. So what I do as a change agent manager, my approach is very systematic. It tends to be based on the Baldrige framework, which I have a lot of experience in and I love. So just really systematic attention to culture. In this case here, I really looked at culture, communication, capabilities, and processes. Those are sort of the 4 pillars to the work that I've done over the last year with my team. So culture, where we went, and there was a lot of team meetings. This came out with a lot of input from the team themselves, as well as our senior leadership. And I'd had meetings with each group individually, and we had some meetings where we all came together as a group for discussions about our purpose and what we wanted to make of our team. Probably at the top of the list, and probably the most dramatic change for this team was the adoption of a customer orientation, which was a different perspective for these folks. Physical presence. When I started, we had, my predecessor had, I guess, a policy, you'd call it, policy with a little p. A lot of folks worked from home. We had flexible work schedules, people working from home too, and even sometimes 3 days a week. It's hard to have a customer orientation when you're not physically present. And it clashed with some of those requirements that our leadership said that they had for us. So we had to make some adjustments there to people's work from home agreements that we have in place. And people need to be here with regular business hours. Team orientation, again, related to the physical presence, our folks tended to work very independently. Researchers tended to remain in their cubes and quietly working on their solo projects. So moving to a team culture, collaboration, so sharing information. Leadership, and that is each, the team members themselves, and they need to take more of a leadership role within the work that they do with each other and with other divisions, and getting organized. I'll talk a little bit about how we did that in a moment. Communication. So we didn't have good communication when I came on board. Just moving to regular meetings with agendas. Expectations for people to come together and report out and share. Also one-on-one meetings, again, that are regularly scheduled and predictable. Shared calendar. We adopted SharePoint in January 2017 as a new tool, and leveraging that for some of our collaboration, information sharing, and using that as a tool, and using a shared calendar so that we had more of a sense of what each other was doing. Capabilities and capacities has been a big topic. So we identified areas of deficiency. We did that first through a process of developing a revised job description in which everyone had a voice in the writing of our new job description, emphasizing these specific capabilities. Bringing in both outside speakers as well as some internal people, having many workshops on each of these topics is something that we've done across the year. And the decisiveness is more of a coaching. That's where kind of I've used my counseling kind of therapy skills to come in and talk about how we can be more decisive and get past some of our fears there. Processes, again, we were using through SharePoint as being a great mechanism to both collaborate on the development of and then the storage of these different tools. We now have work instructions that did not exist before. We have, again, the shared calendar system. We have templates now for many of our most important deliverables. We've done some process mapping on our most key processes, identifying not roadblocks, I'm blanking, but you know, processes, identifying the bottlenecks and addressing those. And lots about making processes more standardized and systematic. Our goal is that if one analyst is working on a project and something happens, another analyst can step right in and take over. People development. I'm a big believer in having a very systematic, aligned approach to recruitment, orientation, training, performance evaluation, and individual coaching or corrective action, and that there has to be that alignment and a theme running through all of them. I already mentioned we completely overhauled our job descriptions with input from the team members and input from our senior leadership on what was needed, and those lined up with our overall purpose. We lined them up with the performance evaluation process, coaching meetings, so areas where my team members were particularly struggling, we would do some formal coaching, even corrective action. In one case, this led to actually a transfer. Employee left and went to another part of the agency where there's a better fit for that person. We had another team member who left the organization voluntarily with our very good wishes both ways because it just wasn't a fit. That's the kind of outcome you want to have as a result of this process, kind of a mix of people staying and developing new skills, but people who aren't a good fit move on. Outcomes, we are tracking our time frames for project completion, and we have cut the time for that. Leader team, we also assess our leader within our team and partners being other teams and other divisions of our agency satisfaction with our work. And we're seeing very good outcomes. It's still early. We haven't even hit the 1 year mark, but it's early in our interventions and we're on a really very good path. All right, when that concludes the speaking didactic portion of this presentation, I hope you all have a few questions, and I welcome those.
Okay, thank you very much, Rebecca. We will open things up here for questions. If you do have a question for Rebecca, please use the chat box. Oh, it looks like you just got a question. Can you see it?
Just, you know what, I hit a button and I made oh, there, it came back. All right, I see a question. Just a minute, Norval. There we go.
From Henderson Thomas.
Oh, Henderson, hello. Just a second, the box is so small. You spoke of the crisis of the healthcare system in the U.S. and showed 43% of beneficiaries are children for Medicaid. But a slide shows about 20% of those enrolled are adults. Is the crisis that those in the program have multiple births without the ability to self-sustain themselves or care for their family? Let's see, 43% of our beneficiaries, Medicaid, 20%, oh, okay. I'm not sure of the question, but I think this is an apples and oranges thing. If those two statistics, data points are unrelated to each other, is the first thing I want to say. The adults that are covered, and Norval, I'm wondering if I can go backwards on my slides to get to the slide that he's talking about.
You should be able to.
Okay. You all can still see my slides?
Yes.
Oh, got it. Okay. Let me just go back in time. That'll help. Probably this slide. couple things. First of all, this is all states. This is nationwide. So across the nation, all states combined, 43% of those on Medicaid are kids. Got it. Okay. This is Virginia only. All right. And of our enrollees here in Virginia, about 20% are adults and pregnant women. These adults are not the parents of the children that are on Medicaid. First, I want to say that. These are not a large group. Most of this 20% right here are pregnant women. I'm now kind of catching up with the question. Most of the people in this 20% are pregnant women, because we have a special program for pregnant women to make sure that they have health coverage. And just a very few, I think it's 1%, are adults. And those adults need kind of a special category we have, and they are adults who have severely disabled children, such that the adult really needs to be the caretaker in the home for the child. And we have a few low-income, poor adult caregiving parents of very disabled children who are insured through Medicaid. Is it the crisis with those in the program have multiple births without the ability to self-sustain themselves or the care of their family? The answer to the last part of that question is I don't know the particular social situation and how many people are having how many children that are covered by Medicaid. Any other questions?
Yeah, you still have some others that are showing up below that one.
Sorry, everyone. The panel's just very narrow. Hard to see. In coaching and performance evaluation, how do you help the individual come up with solutions rather than telling them what they need to change? It's a great question. One thing that comes to mind that I did here is in talking to people both individually and as a group, I really try to get into the team members themselves, the individuals. What do they want? What do they need? And I can tell you here I identified a theme, which is they want to be valued. Most of us do, right? That became, so taking that want, that desire, I think Maslow's hierarchy of needs, and we want to feel affiliation and we want to feel valuable, that we're contributing to our community. So we would have discussions about how do we make sure we're providing something of value to our leadership and to people that, in other units and, across our organization. I often use the individual's language. I tend to not come to them and say, you need to adopt a customer orientation. Rather, I try to use their language, and that's where that value came in. Their language was, we want to make sure we're producing something that's valuable to people. So instead of saying customer orientation, how do we provide something that's of value to our partners? So it really is helping the individual kind of join you by using their language, their frame of reference. Of course, the overarching goal is a goal that my leadership has, and therefore I have, that we do a lot of translating into what I call plain language, or the language or perspective of the individual. Any opportunity to leverage your work to other organizations. Not sure what the question is. Let's see, a little more here. Have you had the chance to integrate Lean Six Sigma methodology in your program? It's a great question too. I have not. We haven't gotten there yet. Meeting the group where they're at, and kind of deploying strategies that best meet kind of the developmental stage of where both the organization and where the team is at. It's probably been a lot more cultural. And kind of setting up very basic rudimentary expectations, making things documented, as opposed to really getting into measurement. That's kind of where we're at. We have done some process mapping though. Since medical laws are continuously adjusting, if an organization creates a system to allow for changing requirements, how would an organization be expected to evaluate the efficiency of those processes? It's an ongoing challenge, Henderson. But my take is, regardless of what's happening outside, our policy analysts, there are core processes that will be in place no matter who's in office and no matter what the regulations are saying that are coming down. So, for example, the way that my people do their work will stay stable. So we look for that stability within the chaos. And then that's where we're going to have to focus our systematic improvement efforts. So we're really looking now in 2018, our plans, we're going to be focusing on knowledge management, developing processes and tools where we can store information, retrieve this rapid fire information, and project management is the other area. So looking at our processes and timeframes for completing projects. So those are what will be measured. What special skills have you planned for the team members to learn and acquire to face the challenges of healthcare? As I just said, the skills that are on our plate to really get into in 2018 are going to be knowledge management and project management. I was surprised that I did not see anything related to cost reduction in your customer requirements. Does the organization place a priority? Great question. It does. The best way I can say it is my team is not directly involved in cost containment strategies that are being deployed for the agency and how the agency manages payments for healthcare. There's a lot of that going on. It's just we're not directly involved. We're more regulatory. Now there are some regulations that relate to cost containment coming down that we are more peripherally involved with, but we're not budget financial process people. Okay. You made many changes quickly. Did your team go through a storming stage before things got better as you were transforming together? They stormed as much as a bunch of introverts storm. So as you can imagine, the psychological challenge can be, and I think I'd rather deal with someone who's verbally storming than someone who's passively resisting. But there's more of a passive resistance that happens, and yes, I have had that. And that you have to confront it and talk it through. And I think I already said, I think part of the storming is that 2 of the 5 that were originally here are no longer here. You're welcome. What keeps you up at night over this program? I think 2 ways I want to answer that, kind of generically, just as a citizen, and then the others as a manager. As a citizen, the thing that's keeping me up at night is what I mentioned when I said it's 2 sides of the coin, or the yin and the yang of all this, is access and cost. And I think that the conservative politicians have sort of hijacked cost, liberal politicians hijack access, to where they polarize the problem, to where if you want to see greater access, then, well, okay, you're against cost. Or if you want to see better cost accounting, well, then you're opposed to access, without really seeing that these 2 are interrelated and 2 sides of the coin, and that the solutions must address both simultaneously. So the thing that keeps me up as a citizen is the continued bickering and posturing and arguing and debating about cost versus access, and then nothing gets done. And case in point is we currently, many of you know from the headlines, the Children's Health Insurance Program, or CHIP, Congress just didn't act. They did not even vote to reauthorize funding for CHIP. So starting in 2018, we're running out of funds, and there's no plan to reauthorize funding or budgeting for that. So that's instability. So we are at November 30th in 2017, and we have no decision certain one way or the other about whether CHIP will be funded in 2018, in fiscal year 2018 for the feds. And so we in Virginia, we will run out of money in February 1st of next year. And that level of uncertainty keeps me up at night. All right, Norval, I think I've hit them all.
Yeah, it looks like you did. Lots of great questions today. Really appreciate folks asking questions. We're always happy to have presenters to answer those. It looks like Henderson had another question. Did you see his?
Oh, okay. Your leadership mentioned if they want more frequent updates of information, are they willing to commit the time for this? Yes, thanks, Henderson. One of my surprises that I've never experienced this at any other organization where I've led a change effort. I had some resistance within the team, as I already mentioned, but across the organization and the leadership, the changes we're deploying are being warmly welcomed, enthusiastically cheered. And what we have here is through the chain of command, through my director and then deputy director above him, they both have this very open door policy, and it's worked out really well. The preference is just drop by my office and tell me. Now, most of that communication is channeled through me, and so, I'm real careful with communication, and I'm very, very speedy with it because I come from a hospital environment. So I use an SBAR, in other words, SBAR communication. Yes, they're very committed to this transformation effort. It wouldn't work without it.
Okay, that looks like that may be the last question.
And my email's on those slides, Norval. Anybody can email me and ask me questions that way. And also, just really quick, Norval mentioned that y'all do a post-presentation. You give feedback, and I would really welcome feedback on my presentation. I'd like to improve.
Yep, so we will be sharing the link to a feedback survey, as we mentioned earlier, as well as a copy of Rebecca's slides, a PDF copy of that. So you'll have her contact information in those slides, as well as a link to the YouTube recording. So if you missed something, you may have come on a little late or had to leave and come back, you can always go back and view it at your own convenience and see what you might have missed. So anyway, we are running up close here to the top of the hour. We are a little bit past the top of the hour. So without if there's nothing else, we're going to go ahead and call it for today. One last quick reminder, our next webinar is on Tuesday, December 5th. That will be Karen Maskell with Change Management. That will be at 12 noon Eastern time. So many of you have registered for it. If you haven't, there's still opportunity to do so. And we look forward to seeing many of you online with this on Tuesday. And with that being said, we'd like to thank everybody once again for being with us. Thank you, Rebecca, for presenting for us. And we hope everybody has a good rest of the day. Thanks now. Bye.